I'm Nicole Theodoropoulos. I'm an infectious disease doctor at the University of Massachusetts.
And hi, I'm Cameron Wolfe. I'm also an infectious disease physician at Duke University in North Carolina. And Nicole and I both work significantly with people undergoing organ transplantation. We want to talk to you today a little bit about donor-derived infections. And so these are things that you might have heard of already as part of your evaluation so far, or as part of family members who, or loved ones who are getting evaluated. And we sort of want to talk a little bit more about some details about some rare issues that we need to think about when it comes to transplant, and sort of how we as clinicians and how you as people going through this process need to sort of think about that. So in actual fact, it's probably worth taking a step back and sort of thinking that when we talk about things that can come from donors with an organ, we often sort of split those into three things. We think about infections that very occasionally come with donors. We also think about rare issues related to, for example, cancers, and very rare things that can occasionally pop up that include things such as allergies. And so even though the vast majority of people, none of these things really play out in the safety of a transplant, we want to sort of talk about a few of the more uncommon things that we all think about and that we think general community members should be aware of. So Nicole, maybe a good place to start off is how common do these sorts of things even turn up in transplant? Is this rare or common, or give me a sense?
So very rare. I mean, I think we've used the word rare a couple times already. We have estimated that infections come from donors about 2 in every 1,000. That is really hard to imagine with your brain. But let me take a step back a little bit, and we'll talk about what we even do when we go out to evaluate a donor. So obviously there can be living donors. We have living donors for both kidney and liver and sometimes other types of transplants. And we also have deceased donors. We evaluate them pretty much the same. The biggest difference is going to be the timeline that we have to evaluate them. When we have a deceased donor, that timeline is really short. So basically the team that goes out has to evaluate the patient within a day or two, really, to get all the information. With a living donor, we have a lot longer time to talk to the donor, to figure out what they've been up to and to screen them. So when we evaluate a donor, this is extremely simplified, but a few things that we do, we actually obviously want to make sure that their organs that we're going to use are working well and will work well in the transplant recipient. So they'll evaluate the quality of the donor. They also do a pretty significant what we call social or behavioral history. That's usually from a next of kin, a loved one, who's able to give information about what the donor has been up to in their life. Have they traveled? Where were they born? What did they do for work? So those are things that we do collect and help us anticipate certain infections that they might have been exposed to. Also active infections. A lot of times donors come in sick from an infection, or we're in the hospital for a while with an infection. So we do things like take cultures of their blood and their urine, also of their sputum and their respiratory tract, to make sure that they don't have an active pneumonia or active blood infection. This won't rule out a donor necessarily, but we need to know these things up front to protect the transplant recipient. A lot of what we do also is testing for what we call latent infections. And what that means is, there's a lot of things we've been exposed to in our life that stay with us for our whole lives, even if we don't know they're in our body. It sounds kind of creepy, right, a little? But a lot of those are viral infections, for instance. One of the most common viral infections is something called cytomegalovirus, or CMV, and that's one that we check for. And I think one of the most common ones that people think about when we talk about these infections that can remain latent is something like the chickenpox virus. If you're infected when you're young, that virus stays with you forever and can come back as shingles. So these are the types of viruses that can, what we call reactivate, and can reactivate after transplant. Yeah. So we check for a lot of those viruses. So Cam, what would you say if a donor came back and had evidence that they were exposed to CMV, for instance, and let's say that the recipient you were hoping to give a kidney to had never been exposed to CMV, would you still take that donor?
Yeah, it's a great question. So yes is the simple answer, but I think what you're also getting at is that many of these same tests that are done on our donors are also done actually on our recipients ahead of time, such that we can really understand what's the match going to be here between things that the donor may have seen and things that you may have seen or not seen? And in that situation, it's important to understand how common some of these things are. Right. So for CMV, for example, for adults, probably 75% of everyone has been exposed. And so for me, if I find a recipient who's CMV negative, usually, in fact, I would unduly delay their transplant if I had to wait to also find a donor who was also CMV negative. Right. And so, the other part of that is that for many of these things, we have really good treatments that can actually prevent infections coming. So even if I recognize that a transplant will carry CMV to an at-risk individual, I can intentionally place that person on medications to stop that waking up. Right. It's very helpful. So, when we sort of think about these are all the things that we can predict and we know ahead of time. Tell me a little bit about what would happen if, for example, you've moved forward with a transplant, it's great quality organ, but then you get a call to say, actually, one of the donor blood tests was positive.
Right.
What does that do?
Yeah, so if a blood culture turns positive, which, this is pretty common, say a blood culture turns positive, we get called after the transplant, luckily we have great antibiotics, and so we can start that recipient on antibiotics to treat the blood culture that was in their donor as if they were infected. We presume they were infected, and we give them treatment for that. And, I would say, 99.9, out of 100 times, that's extremely successful and there's no problems. So, there's things like, obviously, if a urine culture comes back positive and you took a kidney, you would want to treat that as well. So we think about the organ that's involved and whether or not we need to treat.
And in fact, sometimes we'll know that the donor has a positive blood culture and still be so confident it's a great quality organ that we'll go ahead, but intentionally trying to treat this all the way through.
Right, exactly.
Yeah. So what about some things that would be unexpected? Like, let's say, this is not a complete testing panel of everything. What about flu?
Right. I mean, Cam did a great job of talking about things that we expect ahead of time and how we kind of avoid some complications from them. But unfortunately, there's a wide range of things that we can't test for. First of all, we don't have good tests for, or we're not anticipating them to be a problem. So for instance, someone comes in and is unfortunately in a car crash, and they become ineligible to donate their organs. But let's say they were also infected with influenza or the flu right before they came in, but they weren't showing any symptoms of that. They could potentially pass the influenza on to the lung transplant recipient. And so those are things that we wouldn't have tested for ahead of time because the donor was not having any problems with influenza. So there's things like that, and there's also extremely rare infections that are sometimes involved or not involved with the donor's death that we can't anticipate.
So the nice thing about these is it really does eliminate the risk or minimize the risk that comes with anticipatable problems. Although, there are some rare unanticipated ones that still exist, and that's certainly true.
Exactly.
Occasionally that even moves so far as to say, these days a lot of people will hear about hepatitis as a potential where we'll in fact, your center will in fact intentionally talk about, hey, maybe we have a donor who's got a great quality organ, but we know they're hep C positive. Would you still take that organ? And in fact, those sorts of changes are now possible in an era where hepatitis treatment enables me to then cure people on the back end.
Right.
And so this is an area that's a little bit in flux. Mm-hmm. So if you were to look at this, we've sort of outlined a timeline here. Someone's moved through with a successful transplant. What would they expect to feel or notice or sense if they were running into a problem with infection post-transplant?
Yeah, so usually right after transplant, the first month, the main thing that we see is infections related to the surgery itself. Often the surgeries are complicated. They're hooking things up together. There can be surgical complications. That's usually what we see very early on. Sometimes bacterial infections that come with the donor that were not anticipated, or extremely rare viruses can show up early. Usually if you're going to have an infection transmitted from your donor, we think it comes between 1 to 3 months, but we have seen these anywhere within the first year. Between 1 and 6 months, you're probably at your highest immunosuppression, which means your immune system is at its weakest, and so things that are in your own body or coming from your donor can cause problems at those times, like the CMV that we talked about. And then later on, after 6 months or further, we we often see things that you pick up once you go home, like a regular pneumonia or a urinary tract infection. So again, these are rare, and we talked about that, 2 in 1,000 people getting these unexpected, what we call donor-derived infections. And just to compare to some, to put it in context and things you actually think about in your regular life. Here's an image of the risk of getting HIV or hepatitis C from a donor who maybe had some high behavioral risks. And so there's a half a person out of all these people. That's kind of the risk if you want to visualize it. But how about risk of dying in the next year if you're waiting for a kidney transplant? A lot more common. Additionally, risk of dying in the next 3 months if you have liver disease with a MELD over 20, extremely common. And we have risk of dying in your life from a traffic accident, a risk we take every day. So that's more common than the risk of getting infected. So these are very rare.
There's a great summary there, isn't there? As scary as hepatitis and HIV may sound, the actual risk is meaningfully less than sometimes the risk of not taking an organ transplant.
Right, so taking the small risk, but avoiding waiting and the possibility of, succumbing to your disease is a lot scarier, I think.
So we just want to conclude by saying, look, you will become aware of many tests that you or your loved one going through transplant are going through. Be aware equally that donors, be they living or deceased, will have the same sort of testing. And much of what happens in the background is an attempted match and then an attempted mitigation of any risk that we see coming ahead. And at the end of the day, transplant from an infection point of view is pretty safe, and hopefully you'll begin to understand that. So thanks for listening.
Thank you.